topic is on redo TAVI indications, planning, and outcomes. So here are my disclosures. So I want to first of all thank a number of people who have been pioneers in the field of redo TAVI. You can see them here, and we are still learning as we speak. So this seminal European Heart Journal paper talks about the lifetime management of patients with aortic stenosis. And you can see that if you're young patients, you're more likely to need more than one intervention in your lifetime. However, once you get to 60s or so, maybe a second one is enough rather than two more interventions. So it's very important to think about what your first valve selection and choice is going to be. And you can see that since 2020, there have been a lot of publications now on the topic of redo TAVI, and it's still expanding. In the United States, you can see TAVI explant for failed TAVI has now become the most fastest growing operation in the United States. And you can see that just in the span of a couple of years, it's 150% growth per year. Now, contrast with the redo TAVI, you can see the volume actually are pretty similar. Obviously, we don't have the most recent data, but you can see that here. Despite that, you can see that TAVI explant is a highly morbid operation. Mortality 15%. The mechanism tends to be 64% of structural and non-structural valve deterioration. So this is our own registry looking at redo TAVI versus TAVI explant. From the same centers, you can see that if you have structural valve deterioration, you're more likely to have redo TAVI. But if you have severe PPM, then you more likely need to have TAVI explant. And you can see that here, obviously, TAVI explant is a higher risk operation than redo TAVI. But you can see if you survive at 1 year, afterwards, the survival curve appeared to be similar between the two groups. And in the United States right now, redo TAVI is still rare, but I can tell you just these 2 months, September, October, we're already seeing more patients coming with TAVI failure. However, having said that, the outcomes tend to be excellent, very low mortality. You can see that here's low stroke rate and low pacemaker rate. But yet to see what valve you're going to put in first versus second. So if you have your first valve being a balloon expandable valve, you can see that your gradient is going to be higher when you do redo TAVI. And also, interestingly, if your first valve is a balloon your second valve is a balloon expandable valve, you can see also the gradient may be higher as well. You can see that this is a large TVT registry paper looking at the balloon expandable valve SAPIEN 3 platform in redo TAVI from JAMA. And you can see that at 3 years, there have been no difference in survival between that and native TAVI. And also, it doesn't matter what combination you have, whether it's Edwards and Edwards or Edwards and non-Edwards. But redo TAVI does have higher gradient after the procedure, and also a smaller EOA, so there could be a risk of PPM afterwards. If you look at the combination, again, balloon in balloon versus balloon in non-balloon, there's no difference in death or stroke. But if the gradient in balloon and balloon is going to be higher than balloon and non-balloon in redo TAVI based on this registry. So what do you do when you see such a patient? So first of all, you typically diagnose by echo, but you also need to have TEE, CT, and aortic angiography for workup. So depending on the mechanism, if it's structural valve deterioration, and if you can do redo TAVI, then you should do that because that's safer than TAVI explant. But if TAVI explant is necessary, and the patient is operable, then that should be done. If it's non-structural valve deterioration and the mechanism is PPM, if they can be operated, that's the only option, as I shown before. But if they are not a surgical candidate, and if you can do redo TAVI, then maybe you can help a little bit. Usually with failed balloon expandable valve, and so your only option is going to be putting a self-expanding valve in there, usually a supraannular valve, to be able to improve the hemodynamics. If it's PVL, then you need to consider post-dilatation as typically becoming done. If it looks solved the problem, then no further action. But if you cannot, you might need to consider redo TAVI to increase the radial force to seal against the seal zone. Now, if that's not possible due to coronary obstruction, then you need to consider percutaneous closure. So this paper I was succeeding author in the JACC intervention, looking at step by step on how to work up these patients. and also the new vocabulary now that you learn from the circumvention paper that we published looking at neoscript plane, where it is. It depends on the height of the valve and where the valve is located. Leaflet overhang, frame expansion, those are all new terminology that you need to be familiar with. So the analysis is combination specific, and so I'm going to walk you through some of the concepts. The first one is that there are 4 combinations: short and short, tall and tall, tall and short and tall. And with short and tall, that's more combinations in terms of variation. Next, you need to figure out the landmarks of each valve. So for example, the sapien valve, the top of the commisure's tab is where the wrist plane is going to be. Versus the evolute valve, you can see there are multiple nodes depending on where you put your second valve to define the neoscript plane. The coronary wrist plane is the lowest part of the coronary ostium. So you can see that the middle case, you have the left main and the right coronary below the neoscript plane. So you need to assess for coronary obstruction versus the one on the right. You can see the left main is just above the above the top of the frame. So you can see there should not be any issue. The top of the leaflet, as I mentioned before, is important to see where the skirt is going to be. And you can see that the combination matters because of short and short or tall and short. You're going to have the entire short valve being the neoskirt plane and ceiling. Tall and tall is going to be higher. But if it's short and tall, you can see that depending on where the second valve is implanted, your neoskirt plane moves and shifts upward as you go from nose 4 to 2 or low versus high implant. So you can see that on the left side, if you have your neoskirt plane above the coronary wrist plane, you need to look at the distance to make sure there's no obstruction. Versus the right side, you can see both coronaries above the coronary wrist plane, neoskirt plane, so there's no worry about coronary obstruction at all. So what do you measure here? Use that on CT scan, you measure the valve to coronary distance, valve to aortic sinus distance, and finally valve to STJ distance, because often the neoskirt plane goes all the way up to the STJ of the anatomy. Now, not just the neoskirt plane, the coronary wrist plane, but you also have to account for frame expansion. What I mean by that is that when you put the second valve, or even when you pre-dilate the first valve, the frame of that valve expands further. So that could actually reduce your valve to sinus or STJ distance, where you think, oh, I'm going to be okay, but in reality, you might actually cause coronary obstruction. Now, the other concept that we have talked about before is interesting, is called leaflet overhang. What that means is that when you put your second valve inside the first one, the first valve leaflet drape over the second valve and may lead to dysfunction. However, we have now noticed that we used explanted TAVI specimen, and we found that when we put the second valve, it does not really have that much an impact. In fact, because these leaflets are stiff, they're fibrosed, they may have calcium deposit, they don't really move that freely, unlike you see on the right side of the video. Now, when you need to look at a pre-TAVI CT, I think that you should do it all the time to guide your planning, because you might want to know whether it's bicuspid or tricuspid, how well the valve expanded, are they undersized or oversized? Can you pre-dilate this first valve to optimize the landing zone, because you don't want to have a root injury. And you can also use the coronary and sinus height as references to determine the implant depth of the first valve. So here's an example. A patient with a 26 sapien 3, you can see that was quite oversized. As a result of that, you can see the frame actually is quite underexpanded, and that's probably why it failed. And you can see that to do that, we will pre-dilate the valve, but we don't want to be too aggressive, because even though it's 26 S3, if you do 26, you might rupture the root. So we do 25 only, and then when you put the evolute in, you then post-dilate with the same balloon to maximize the frame expansion of the evolute and also reduce the frame-to-frame leakage. So I've done videos of this on YouTube. I'm going to update them soon, because now I found a way to work these patients up on Premencio, but also utilizing the concepts shown in the Redo TAV app by Vinny Bapan. And if you want to learn coronary access after TAVI, you can use my colleague and friend Anna Punakini and the TAVI Cap 8. So you see that the sizing chart is included in the app, but also you can actually go through step by step on the app, and also this is part of the paper that just published in JACC Intervention, going over all the details of the app. Now, fluoroscopy is also important, in my opinion, because you actually higher resolution than CT. You don't have any artifacts, and you can actually directly plan the procedure in terms of figure out where to put the second valve in the outflow position when you deploy. Because when you do the sapien valve and the second valve, sometimes the valve move up or move down, so you have to anticipate that. And so you need the fluoroscopy to be able to guide you to do that. Typically, we do an LAO cranial projection to take the parallax out, and also make sure you overlap the cells and the diamonds, so it makes the visualization easier. And then you do your aortogram to look at the neoscript plane versus the coronary wrist plane. So here's an example of portico valve. You can see that here we take the parallax out. This is with a low implant at the node 2 of 1 full diamond, or this is a high implant. You can see high implant, no problem with coronary obstruction. So that's what we will recommend. Now, but sometimes CT can be deceptive. You can see that here, this patient looks like might be trouble with a redo TAVR, but you can see that in the angiogram that the valve was actually implanted deep, so there's no problem at all with the second valve. Now, look at this one here in the middle. We think that you might be able to do the redo TAVR, but look, you can see the sapien frame is completely sealed off against the STJ here, so this would not be possible unless you put the second valve deeper, like right around here at the outflow. Now, this one is a sapien classic. You can see that here, the angiogram show the frame actually much closer to the left main than you see on CT. So this case will be challenging, and you have to plan about how you're going to put the second valve in without causing coronary obstruction. And you might have to use a balloon expandable valve and implant outflow instead of a self-expanding valve, which can shift and put the leaflet out to the left main, and also the inner skirt to be sealing up about the STJ, and you can cause primary with coronary access. So here's some examples with TAV and TAV. You can see that a tall and a short combo, a short and tall combo, and a short and tall combo with different self-expanding valves. Now, what about coronary access after the second valve? Well, you have to be careful because you cannot overlap the second valve and with the first valve perfectly. So we typically don't use the tall and tall combination for this reason, because now the cells are much smaller to engage. But what I would say is that it's very important also to think about what your first valve will be and where you're going to put it, in terms of, because the patient might ask, can I get a redo TAVR in the future? So this paper on the left we published in Circulation Intervention, looking at the redo TAVR feasibility based on simulation of the first valve. You can see that when you implant the valve higher, your redo TAVR feasibility goes down. And now we're also looking at the Navitor as well. With the Evolut, you've already seen a lot of data out there, but this has not been done so far with the Navitor valve. So you can see that it's very interesting in terms of the feasibility. So in summary, I think redo TAVR and TAVR explant for failed TAVR, you can see that will be the fastest growing procedure in the future. The short-term outcomes for redo TAVR so far so good, but we don't know the durability and hemodynamics. But we do know balloon and balloon valves tend to have higher gradients. You need to know the new terminologies that I mentioned, new device designs to evaluate the redo TAVR feasibility, planning and executing the procedure safely, and redo TAV app and the fluoroscopy analysis are both simple tools that you see, but actually critical in terms of workup to make sure you pick the right patient, you plan the procedure, and also anticipate for complications. Thank you very much for your attention, and happy